Hello, everyone, and welcome to today's Third Thursday webinar. I'm Dave Iverson, the Michael J. Fox Foundation's contributing editor and the moderator for today's webinar. A reminder that you can log in every third Thursday of the month at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a discussion and to ask questions about an important topic to the Parkinson's community. So we hope you'll continue to mark your calendars and join us throughout the year. This is our first Third Thursday webinar of 2016, and we hope you'll continue to join us throughout the year this year. As always, you'll be able to submit a question throughout the hour, which our experts will be answering during our presentation. There's a little Q&A box near the middle of your screen, so you can just type in your questions there, and as always, we'll do our best to answer as many as we can. The good news is that the webinars have continued to grow in popularity. We have 5,000 people registered for today's, which is great, except of course it also means we won't answer every question that we get, but we'll do our best to get to as many as we can. But there is a bonus opportunity. Tomorrow, if you go to the Michael J. Fox Foundation Facebook page at 12 Eastern tomorrow, we're going to have a follow-up Q&A session on dyskinesia, so it'll be another opportunity to ask your questions if we don't get to yours today. And last, just want to add that we'll also, the slides from today's webinar are also available for download. There's a box called Resource List on your screen, and so if you just click on that link, the document will open in a new browser window, and you'll be able to save these slides or print them later today. All right, let's get started with today's topic, dyskinesia, what to do about moving too much. Here's some of the topics we're going to cover. We really want to try to give a good definition of what dyskinesia actually is, because it can vary in terms of what it means to each individual. Talk some about the causes of dyskinesia and about the current treatment methods for dealing with dyskinesia. And then we'll also turn later in our program to the new therapies that are in development to both avoid dyskinesia altogether or to treat it if it does become a reality. Here are the people who are joining us today. Jean-Pascal Van Houten is from Orange County, California. Jean-Pascal is 48 years old, was diagnosed very early at the age of 32. And deals with dyskinesia as part of his Parkinson's experience. Jean-Pascal, thanks very much for being part of our session today.
Yeah, thanks for inviting me.
We're happy to have you with our program. Joining us as well is Dr. Christopher Bishop, who is with the State University of New York at Binghamton, professor of psychology and also chair of the Behavioral Neuroscience program. Dr. Bishop, thanks for being part of our program today as well.
Thank you. Happy to be here and for the opportunity.
And last, Dr. Joe Jankovic. Dr. Jankovic is professor of neurology and distinguished chair in movement disorders at the Baylor College of Medicine in Houston, Texas. He's also the director of the Parkinson's Disease Center and Movement Disorders Clinic at the Baylor College of Medicine in Houston. Dr. Jankovic, thanks also for being part of our webinar today.
Well, I'm delighted to participate in this webinar.
All right, thank you all. Well, let's get started and talk some about what dyskinesia is. As you see on the slide, it's that uncontrolled movement, sometimes seen as kind of like a dance, a sort of wiggling or jerking movement. And we want to talk about what it is first and how it comes into being, and get both kind of the definition from an expert point of view and also a different kind of expert point of view, a more personal perspective on this from Jean-Pascal Van Houten. But Dr. Jankovic, start us out with your best layman's definition, if you would, please, of dyskinesia.
So the term dyskinesia just means abnormal involuntary movement. It could be in a form of jerk-like movement that can involve any part of the body. The most common form of dyskinesia that we see in patients with Parkinson's disease who are treated with levodopa is what we refer to as stereotypy. And the word stereotypy just means repetitive movement such as head bobbing or sort of a swaying movement of the upper body or trunk. These are probably the most common forms of dyskinesias. Another type of dyskinesia that can occur, particularly when the L-DOPA wears off, is called dystonia. Dystonia refers to spasm of muscles causing abnormal movements or postures. Probably the most common form of wearing off dystonia is flexion of the toes. So the patients often describe cramping of the toes, especially on awakening or when the cinemat wears off, and that is referred to as a wearing off dystonia. So dyskinesia can be manifested by a variety of abnormal involuntary movements, and the ones I described are probably the most common in patients with Parkinson's disease who are treated with levodopa.
And we see on the slide, Dr. Jankovic, that question of being treated with levodopa, the standard, of course, gold standard Parkinson's medication, combination of levodopa and carbidopa that so many of us take. And why is dyskinesia a side effect of that? Can you describe what it is about particularly long-term use of that drug that seems to trigger these dyskinetic effects?
So obviously not every patient with Parkinson's disease develops dyskinesia as a side effect of L-DOPA. With continued use of L-DOPA, particularly young onset Parkinson's patients may start having these involuntary movements. So initially they may notice this swaying type movement or eventual head bobbing, and that is usually the early sign of levodopa-induced dyskinesia. So patients with Parkinson's disease, if they are not treated with levodopa, usually do not have dyskinesia, but they have other kinds of abnormal involuntary movements, typically tremor. And it's very important for patients to differentiate between tremor, which is due to Parkinson's disease, versus dyskinesia, which is a side effect of L-DOPA. And I can give you an example why it's so important. So not long ago, I saw a patient with Parkinson's disease. She complained that she was too slow and that she had some stiffness of her muscles, and she had quite a bit of tremor. So I increased her cinemat, and she called me 1 week later and said that her tremor got worse. Well, that didn't make much sense, right, because L-DOPA or cinemat improves tremor. It doesn't make it worse. But I asked her to come in so I can examine her. And when she came in, she actually had this repetitive movement of the right arm, which she interpreted as tremor, but in my opinion, it was dyskinesia. And so, again, it's very important that the patients who take levodopa are educated about this particular side effect and understand the difference between tremor, which is a typical feature of Parkinson's disease, and abnormal involuntary movement that I described as part of dyskinesia.
And in a moment, we'll talk more about how to deal with dyskinesia, what can be done right now in terms of modifying those effects, and also what research is underway to improve those treatments. We want to hear from Jean-Pascal Van Houten in just a moment about his own personal definition of dyskinesia. Before we get to you, Jean-Pascal, I just want to ask Dr. Chris Bishop if he would comment briefly on the last bullet point on this current slide, which is that while we've long associated dyskinesia with long-term levodopa use, we're also now learning that there is a connection to the disease itself, to both the length and the progression of the disease. So does that mean, Dr. Bishop, that there's a kind of interplay that goes on that's a combination of both long-term levodopa use along with how far advanced your disease is?
Yeah, I think as we begin to understand more about how dyskinesia develops, we're beginning to find that certainly as an individual takes levodopa a number of years, that contributes to the development of dyskinesia, but at the same time, with Parkinson's disease, where it is a progressive disease, and so as more cells are slowly being lost as a result of the disease, the brain is changing along with that, and so longer progression of disease is more likely to increase the chances that dyskinesia would develop.
And one quick follow-up question back to Dr. Jankovic for just a moment, and then we'll hear from Jean-Pascal. which is already people are writing into our webinar today, Dr. Jankovic, and this is a question you hear from people living with Parkinson's a lot, which is, should I hold off then taking levodopa, carbidopa, so that I'm not as prone to getting dyskinesia later on in the course of my disease?
Well, this is a very important question and also a very controversial issue in the treatment of Parkinson's disease. There's no doubt that patients don't develop dyskinesia until they start taking levodopa. So intuitively, one would think that delaying the onset of levodopa therapy would delay the onset of levodopa-induced dyskinesias. And that indeed is true in some cases. But if you look at 5-6 years down the road, those patients who delayed levodopa therapy versus those patients who started on levodopa therapy early, there's not that much difference, 5-6 years after the initiation of treatment. Nevertheless, particularly in young patients with Parkinson's disease who are most likely to develop levodopa-induced dyskinesia, I think it's prudent practice to try to control some of the early symptoms with medications other than levodopa. So in early stages of treatment in young onset Parkinson's patients, we may, for example, use monoamine oxidase inhibitors such as rasagiline or Azilect. We may use dopamine agonists such as ropinirole, pramipexole. So these are relatively mild medications that may be mild for patients in advanced stages of the disease, but may be satisfactory in providing control of symptoms in early stages of Parkinson's disease. And those medications may delay the need for L-DOPA. In fact, there have been several studies that have shown that early administration of Azilect or ropinirole or pramipexole may delay the need for L-DOPA and therefore may delay the onset of levodopa-induced dyskinesias. But whether it makes any difference, 5-10 years down the road, that is still a matter of controversy.
We'll come back and talk about that more later in our program. But for now, let's also turn to Jean-Pascal Van Houten, who was diagnosed, Jean-Pascal, at an early age of 32, has lived now with Parkinson's for 16 years at 48. We're going to actually see a little video of you in just a moment, Jean-Pascal. But before we see that video, why don't you just describe for us what your experience is with dyskinesia and how you view living with those effects?
Yeah, good morning, good afternoon, everyone. I'm very happy to explain what my experience is. First of all, I think the dyskinesia, as we have been talking about, is annoying. However, I still take it every day rather than paralyzation, which is the opposite. When the medicine doesn't work, I get paralyzed and there's pain associated with that. And the dyskinesia is when I feel like the medicine works, and sometimes the medicine works better than other days. If it's turbo boosted with coffee or whatever, each individual find their own way how to work with the medicine. It's like more of an art to administer the scientific way of getting your medicine in your body, but the effects, it all depends on what you eat, what you drink, and what your activities are during the day. So for me, I'm still going to work every day, and it's like, thank God I am somebody that doesn't care how people look at me, but I can imagine for a lot of people it's disturbing when they wiggle and have a lot of attention focused on them, because people will watch and look at you, so it's uncomfortable. However, I save on going to the gym, and I have not, I don't need to have a workout routine on top of the one I have in the morning.
Well, let's take a look at some of what your experience is. We're going to show everyone now a short video that is Jean-Pascal self-narrates while he's in the middle of doing something that he enjoys very much. So let's take a look at that video.
It's very important that you always try to do something that you enjoy.
All right, are we able to take a look at the video?
It's very important that you always try to do something that you enjoy and that you can excel at.
Looks like it's
And
loading,
therefore,
but
one of my
let me talk
passions is
you through it.
sailing.
Basically,
It's also
my
very
motto is you
calming,
need to keep life
quickly,
interesting and fun as
calming
much as
and
you can, you
nurturing
know?
my brain
And still go
to relax
snowboarding
and enjoy life.
like bicycling.
That's its greatest
And one of the
moments.
things that I'm going to show is the video.
Or later. Ciao.
All right, apologies everyone. We seem to have a little bit of trouble with the video loading, and you could hear, some of you may have been able to hear Jean-Pascal in the video and also talking live as the video progressed. But let me ask our associates in New York if they can try playing the video once more, and we'll see if we're able to screen it. So Maggie, if you can initiate the video again, let's give it a try.
It's very important that you always try to do something that you enjoy and that you can
All right,
excel at.
doesn't look like we're able to
And
do that.
therefore,
My
one of my
apologies.
passions is sailing. Also
David,
calming,
Dave,
no,
this is Dr. Jankovic. I can see the video very nicely on my screen, and maybe some of the other participants can see it as well. So, I'm just looking at Jean-Pascal. I guess he's on a boat showing these involuntary movements that we were talking about earlier. We would classify these as choreo, like a dance-like movement, like choreographer. So although I couldn't hear him, I could clearly see that he has this choreatic movement that is one of the more typical forms of dyskinesia, particularly in a young onset patient with Parkinson's disease.
Thanks, Dr. Jankovic. Jean-Pascal, back to you for a moment. And we're just going to, hopeful that the image that's on the screen now is a picture of you, a still frame of you smiling on your boat. Describe, if you would, something more about your philosophy, I guess, of living with dyskinesia and the way in which, as you say, you choose more movement rather than less.
Yeah, as I said before, I think it's a terrible disease, especially when you get paralyzed and stuck. And, let's face it, Parkinson's disease sucks, right? But I think what I have learned to do is I use it as an opportunity to educate people whenever I can about the disease, because people look at you and they're like, what's wrong with the guy? Is he on drugs? Yeah, I'm taking medicine, but I have Parkinson's disease, and especially since I'm younger, people don't really expect it that they run into somebody at such a young age with Parkinson's disease. However, with the Michael J. Fox Foundation, we have had way more attention on the disease overall, so that's good. But
Thanks,
here, also, sorry, one more thing. I think one of the key elements of dealing with the disease is to have a really good team around you. And that means like the physicians, the friends and family and people, you have to educate them, and so they will be there to help you and assist you when you need. But you also have to give back.
As you are, I know, in so many ways. It's great to get your perspective on this, and we'll continue to hear from Jean-Pascal Van Houten as our webinar progresses. Let's move on to our next slide and spend a little bit more time talking about when dyskinesia occurs within the course of the day, and that will then lead us into the ways in which we can deal with dyskinesia and talk about the treatments that are available, and we'll start taking all of your questions as well. As we look at this particular slide, Jean-Pascal, maybe I'll ask you to comment on this first. We see in the slide that when the medication is working at its best in that sort of dark blue center area, everything is going well, but then it can kind of almost accelerate. Can you tell us a little bit more into the dyskinetic movements? Can you tell us a little bit more, Jean-Pascal, about what your experience is like? You were saying earlier that you chose movement over paralysis. When you take levodopa, carbidopa, is there a period of time when things are balanced pretty well and then you get more dyskinetic? What actually happens?
Yes, and you know, from day to day it varies. It is really important for me personally to start my day off in a way that I do my exercise and have a proper nutritional diet and don't mess up on that end because that throws my whole day off. But I can more or less like time my medicine better when I know I have the routine of eating the same thing every day or drinking the same kind of juices every day. That way I can control my disease way more and fine-tune it. But the waves, you know, the key element is to make the waves as long-lasting and as flat as possible so they will end up most in the dark blue area.
So to stay in that dark blue area, it helps, I think, to understand a little bit more about the causes of the levodopa-induced dyskinesia, along with the way in which this ties into the way the disease is progressing, and that will then take us into how to treat this. We see on the slide here that there is this interplay between the way in which long-term levodopa stimulates the brain, and then as the disease progresses, that the nerve endings become perhaps somewhat more sensitive. Dr. Chris Bishop, to help us understand this, take us a little bit further into what's going on then that will help us understand how we can treat it. If levodopa is, in a sense, doing too much and the brain is less able to process that levodopa, what does that tell us then about what needs to be done when it comes to treatment?
Absolutely. So, you know, in the previous graph, there is a period at which movement seems to be well controlled. And early on in the disease, I think most people would report that their symptoms are well managed, that they aren't overactive, but they aren't paralyzed either. As the disease progresses, these peaks and troughs actually seem to get larger. And some of that probably has to do with increasing doses of levodopa that patients take. And some of it has to do with the progression of the disease, the fact that there are more cells being lost over time, and these peaks and troughs end up becoming more pronounced. Because levodopa is increasing the neurotransmitter dopamine that patients don't make as well, these peaks and troughs manifest, they show up as exaggerated and loss of movement. So our goal in research in this field is really to bring our patients back into that well-controlled area. Let's get rid of those peaks and let's bring up those troughs. And that's really the goal, I think, for us that will extend to the clinic.
So let's talk about how we can keep us in that center part of the trough, as Chris Bishop was describing, what we can do now, and then we'll talk some more about what we can do later. The first point we see on this next slide is adjusting dopamine medication. And Joe Jankovic, you mentioned that you had a patient recently whose tremor was problematic. You increased the levodopa-carbidopa dose, but that in turn prompted what she thought was increased tremor, but was really dyskinesia. How successful can you really be in moderating dosage, titrating dosage to eliminate dyskinesia problems?
Well, so one of the reasons why Parkinson patients develop motor fluctuations and dyskinesias is because the duration of the action of L-DOPA in the brain, particularly in the basal ganglia, gradually shortens. So the patients initially, when they start L-DOPA, may have 6 to 8 hours of benefit from each dose of levodopa. But as the disease progresses and as they continue to be treated with levodopa, this duration of benefit gradually shortens, and some patients may have benefit lasting only 2 hours. I have some patients that have to take L-DOPA every hour because they have such a short-lived benefit from each dose of L-DOPA. So the idea is to try to maintain sort of a steady levodopa levels both in the blood and more importantly in the brain. So one way to do that would be to reduce the dosage of levodopa of each individual dosage, but giving the smaller dose more frequently. So that is one strategy that we use in early stages of motor fluctuations when patients begin to develop the wearing off effect. And that's especially true when patients have not only shortening of the response to levodopa, but are beginning to develop these peak dose dyskinesia that you saw on that earlier graph. So that is usually the first strategy, is to reduce individual dosage and giving the levodopa more frequently.
A couple of people want to know, Joe Jankovic, a little bit more detail on this particular question. Laura writes in, will dyskinesia stop if I adjust my medication? And someone else writes in, why does dyskinesia continue even if I have adjusted my medication routine and I've returned to my previous protocol? So at least from a couple of people's standpoint, and I'm sure you see this in your clinic as well, this is in some ways more art than science, right? I mean, it's difficult to actually get that so fine-tuned that you can rid someone of dyskinesia entirely.
Well, treatment of Parkinson's disease obviously has to be individualized, and adjustments have to be tailored, to the needs of that particular patient. So if we reduce the levodopa substantially, then clearly dyskinesias will disappear. Dyskinesias do not occur unless the patient takes L-dopa. The problem with reducing it too much is that the patients then may turn from being on with dyskinesia to being off. And as John Pascal mentioned from his own experience, he prefers being on and having dyskinesia rather than being off and, as he says, paralyzed. We don't use the term paralysis because there's really no weakness, but there's usually marked slowness of movement and stiffness, and that is the typical off period that Parkinson patients experience. And his experience is very similar to most of my patients who, given the choice between having dyskinesia but being on versus being off and experiencing tremor, rigidity, and inability to move and walk, they usually prefer being on with dyskinesia. So that is, the preferred state for most patients. Obviously, we would like to have the patients on without dyskinesia. That's the desired state where patients would like to be. And so the strategy that I described earlier by reducing the dosage of levodopa but giving it more frequently may help. But in addition to that, there are many, many other strategies, and I don't know if you want to get into that now. What are some of the other ways that we can smooth out the motor fluctuations and prevent the dyskinesias?
Well, let's go ahead and take up the next strategy, which is this idea that if one of the problems is the fluctuations, what about the effectiveness, Joe Jankovic, of the new extended release forms of the pill? Ritari is the one that was recently approved. There are also some new developments where levodopa, carbidopa can be taken in gel form. This requires a surgical procedure, and it's where the gel is goes directly into the intestinal system. Do those approaches succeed in reducing dyskinesia?
Over the years, many investigators and pharmaceutical companies have tried to develop formulations of levodopa that have a more sustained effect. There is currently on the market, for example, Sinemet CR. CR means control release, and that's a presumably longer acting form of Sinemet. To be perfectly honest, I almost never use Sinemet CR because that formulation of Sinemet gets absorbed very unpredictably, erratically, and it doesn't really provide the sustained benefit that we would like in these patients. So there is a huge unmet need to have formulations of levodopa that have a more sustained effect. And that is the background behind Rytary, which was just approved about a year ago. And that is a formulation of levodopa that has both immediate release levodopa, the same levodopa that we see in the standard form of Sinemet, but it has a new formulation of levodopa in it as well that has a much longer action. It's a slow release form of levodopa, and it is this combination of the immediate and slow release levodopa in Rytary that has been shown to be very beneficial to patients with motor fluctuations in that it clearly prolongs the on time. So that is the main benefit of Rytary. So patients who are on Sinemet, for example, taking Sinemet very frequently and experience still wearing off effect, they can be switched from Sinemet to Rytary, and that can often prolong the on time and give the patients a smoother response to levodopa. So that is the main advantage of Rytary. The disadvantage is that the patients have to take many pills, so they may have to take like 3 pills 3 times a day, 9 pills a day. So that's one disadvantage. The other disadvantage is the cost. So many insurance companies don't approve it, and we have to appeal the denial on some occasions. But in many cases, patients are eventually able to get on Rytary and obtain more sustained benefit without these motor fluctuations that we described.
I want to, we'll come back if there are questions about the gel form of levodopa, carbidopa in a moment, but I want to turn next because some people are asking about amantadine, and Chris Bishop asked you to describe that, and then we'll have a couple of questions for Jean-Pascal as well. But amantadine, Chris Bishop, is this drug originally approved as an antiviral for influenza, but it winds up, if you use it off-label, being helpful with dyskinesia. Why is that? What does it do, and how effective is it?
Sure. So in the early 70s, people started using amantadine in Parkinson's disease and noticed that it seemed to improve maybe some of the symptoms mildly of Parkinson's disease, but it also appeared to reduce the side effects, dyskinesia, the topic for the day. And what's interesting about amantadine is it is not acting directly on dopamine itself. So it's acting in another brain system that appears important in modifying dopamine's effects. So amantadine acts on similar neurons that work to help people move and dampen in some ways maybe the exaggerated activity of those motor circuits that lead to dyskinesia. Now, amantadine has been around for a long time, and it clearly has benefits in a number of patients. But it doesn't always work for a number of years. Sometimes it loses its effectiveness, and not everybody appreciates some of the side effects of amantadine. But amantadine has been important for researchers because it was one of the first drugs found to be effective, and it provided us with an opportunity to look at how amantadine was working and begin to work backwards to understand how dyskinesia might develop.
And which will take us a little bit later in our webinar today into some of the research that you're doing as well. Jean-Pascal Van Houten, though, let me bring you back into our conversation and ask you whether or not whether you've tried amantadine or whether you have found any way to modify the dyskinesia that you experience.
Yes, I just went to the dark side of the disease, or the trough of the graph, right? So my medicine stopped working, and so you can hear even in my speech that I'm slower now, and I do get paralyzed. But let me explain. I've tried amantadine, and amantadine was for me like more of it felt like a numbing, like it numbed my I don't know how to describe it, my mind or my body. And I've also tried Rotary, and that threw me totally through a loop, and it didn't work for me. But that's why it's so important, as was mentioned before. Each individual has their own needs, and their own regime has to be developed by them in combination with their physician and Parkinson's specialist. Now, the other thing is I want to make sure that everybody understands that I don't want to, like when you see the video and me smiling and everything, it is not easy life with Parkinson's. It really is difficult, especially in moments when you get paralyzed like I'm now, and my limbs start cramping up. And so therefore, I said earlier, I'd rather be mobile and wiggly than paralyzed. And I do get like totally and I'm not just slow moving. I can't move my legs or my arms right now, but I can still speak. But the other thing I wanted to say is like I have an acronym for you guys. It's S to simplify your life, M for manage your life, I for keeping it interesting, L for live, love, and E for educate, like smile.
Thank you, Jean-Pascal, and thanks for hanging with us during what I can tell is a difficult moment in the cycle through which you're experiencing, and let us know, of course, if it's difficult to continue over the course of this hour. Just participate as you can, but it's terrific to have your participation, and I do know that from having talked with you a number of times in the past, and I know everyone listening today really appreciates the way in which you're adding so much to our conversation. Let's continue with a couple of points, and Jean-Pascal, just chime back in anytime you want, and I'll be back to you for additional thoughts as our hour progresses. But a couple of people want to ask about Duopa now, so let me go back to Joe Jankovic for that question. We see that on the slide. This is, again, that intestinal gel form of levodopa-carbidopa, which was approved about a year ago for use in this country. And people are interested as to whether or not that's both an effective way of staying more in that good part of the trough, that dark blue we saw earlier on the slide, as well as avoiding dyskinesia. Joe Jankovic, your thoughts?
So Duopa, in Europe it's called Duodopa, but in this country it's called Duopa, is a formulation of levodopa that comes in as an intestinal gel. It's, in other words, it's infused directly into the small intestine. So a gastroenterologist or surgeon makes a small incision in the abdomen, and then he or she advances this small tube through the stomach into the small intestine, and then this is connected to a programmable pump, and the pump then delivers this gel from this cassette over a period of time. In most cases, patients will use this infusion while they are awake, maybe 18 hours per 24-hour cycle. And the idea is to adjust the titration of the flow in a way that would provide a continuous delivery of the levodopa and keep the patient in an on state without dyskinesias. That is, the desired state for patients with Parkinson. And data and studies have shown that this approach of continuous infusion of levodopa can indeed smooth out the motor fluctuations and prevent the development of dyskinesias. So that is a very effective treatment. Obviously, it does require a small surgical procedure. There's a possibility of local irritation or even infection, so that is by far the most common complication of this procedure. but most of the complications occur early on during the first few days of treatment. Once the patient is stabilized, they usually can benefit from this infusion and have much smoother response to levodopa.
Great. Thanks for that analysis. Let's begin to move forward and talk about what may lie ahead in terms of new ways in which we can deal with dyskinesia, and we'll continue to factor in your questions as well. One of the questions that's come in a lot, Chris Bishop, is about whether or not DBS can be helpful in modifying, deep brain stimulation can be helpful in modifying dyskinesia. And there are, of course, new developments, new ways that DBS is being developed. There's also the point at the bottom of the slide about focused ultrasound. Can you tell us, Chris Bishop, anything about the way in which either actual surgical procedures like deep brain stimulation can be helpful with modifying dyskinesia, as well as these new ideas, which is kind of surgery without surgery, the focused ultrasound?
Sure. With deep brain stimulation, probably first and foremost, can be useful with dyskinesia, in part because it often allows the patient to reduce their medication. And we know that the dyskinesia that occurs with levodopa administration often occurs in part because patients need to take larger doses of the L-dopa, and with that comes the risk for the expression of the dyskinesia. So deep brain stimulation reduces the need for levodopa, and therefore that in and of itself can reduce the expression of the dyskinesia. It also is important to note that neurosurgeons are looking at different structures within the brain that might be responsible for dyskinesia or that are better for the reduction of the symptoms themselves. And so some structures within the brain appear to be better for reducing Parkinson's disease symptoms, and other structures may actually provide a little bit more benefit for dyskinesia. I think as we continue to do research on this topic, we'll have a better handle at how to perhaps identify the best structures for the right people.
And Joe Jankovic, on the focus ultrasound, we're kind of starting on the bottom and working our way up here on this particular slide. This is something that's just being tested now. In fact, the Michael J. Fox Foundation is providing a grant for some testing on whether or not focused ultrasound could be useful for dyskinesia. This is where an actual focused laser burns a spot into your brain. So as I say, it's kind of like surgery without surgery. But there's a lot of uncertainty, I think, at this point about its impact, which is, of course, why it's still being researched. Any thoughts on whether or not there's promise in that possibility?
Focused ultrasound has been developed by Israeli researchers in conjunction with researchers at University of Virginia. And this is a procedure where, as you pointed out, sort of a laser is used to sort of burn a small hole, make a lesion in the part of the brain that is targeted. So it has been, for example, tested in patients with essential tremor, and in this population of patients that have mainly tremor, they have no Parkinson's disease, but just have tremor. It was clearly shown that making this lesion in the part of the brain called thalamus clearly improves the tremor. As you pointed out, the Michael J. Fox Foundation is now funding, in part, research to see whether focused ultrasound can also be used in the treatment of dyskinesia. And the idea is very similar to what was just described for DBS, deep brain stimulation. So instead of placing an electrode into the target nucleus and then stimulating that nucleus with a high-frequency stimulus, as is done in deep brain stimulation. When we use focused ultrasound, we make a lesion, and so it does not require any stimulating type devices. It's a one-time, procedure. One of the advantages, potential advantages of this procedure is that if the lesion is too small and the effects are only mild or transient, the researchers, the investigators can go back and actually enlarge the lesion. Of course, a potential risk is that the lesion can be too large and then the patient could be paralyzed. So that's one of the major disadvantages of this procedure. In the old days, we used to do what's called polydotomy, where a surgeon would go in and actually make a lesion, damage the part of the brain called the pallidum. And even though that procedure was quite effective, in many cases it was associated with hemorrhages and would result in paralysis. So that procedure was pretty much abandoned as DBS emerged. On the other hand, there are some patients who would prefer having this one-time procedure, the focused ultrasound, so they don't have to wear this pulse generator, this pacemaker type device that is required for patients with DBS. So the jury is still out whether this is going to be a useful procedure. I think the initial pilot study for Parkinson disease patients with levodopa-induced dyskinesia will involve only like 15 subjects, but we are all waiting eagerly to see what the results will be from this pilot study.
A number of people are asking about more about amantadine. Chris Bishop, Jean-Pascal Van Houten mentioned the kind of side effects that he'd experienced, the sort of numbingness that was disquieting, and I know that's not uncommon for there to be side effects with amantadine. We see on the slide here that there are some new controlled release forms of amantadine that are being developed. Can you say a little bit more about how that might work, and then go ahead and take us into where that research is taking us as far as some of the new processes that you're trying to research about the way in which other neurotransmitters are engaged in Parkinson's and how that might lead to new treatments.
Sure. So in terms of amantadine, it's really one of the few options that is out there now as an adjunct, as an add-on compound that acts on dyskinesia. And it's true that it doesn't work for everybody. Part of the reason why the extended version of amantadine was developed was because amantadine, if it's maintained in the blood and its effects occur in the brain for an extended period of time, it's more likely to continue to blunt those peaks and troughs. And so there have been a subset of individuals that have responded well to this new formulation of amantadine and see a significant reduction in their dyskinesia when they take it. What this highlights, amantadine does as a sort of an education for those of us who do research, is that there are other systems in the brain that can help us to modify dyskinesia that aren't directly related to dopamine itself. One of the things that I talk about a lot with my students and with other researchers is the fact that the brain has an amazing ability to compensate for insult and injury, like the brain undergoes in Parkinson's disease. And part of the process of compensation is neuroplasticity. And that neuroplasticity, changes in the brain that might be positive, help the brain to compensate for the loss of dopamine. Those systems then become good targets for new drugs because those systems may help us to maintain the positive benefits of levodopa, but reduce their side effects. And so a lot of the work that we do in my laboratory deals with investigating non-dopamine pathways within the brain and how those non-dopamine pathways within the brain can improve levodopa therapy. We focus a lot of our attention on a system that's called the serotonin system. The serotonin system is another neurotransmitter that doesn't look all that different from dopamine chemically, but it seems to have effects in a number of the same places where dopamine is working to modify movement. And so by targeting the serotonin system, we hope that we can reduce some of the negative effects of levodopa and yet maintain those benefits that levodopa clearly continues to have throughout the progression of the disease.
That does sound like a lot of promising possibilities that lie ahead, and we're going to use the last moments of our webinar today to talk about both what additional developments there are in the research world as well as take the rest of your questions that we can. Jean-Pascal Van Houten, one question comes in for you, which is just interested in when dyskinesia started with you. Dr. Jankovic mentioned earlier that people with young onset Parkinson's like you are more prone to having to deal with dyskinesia. Did dyskinesia start early on in the course of your Parkinson's experience?
No. Well, it's all relative, right? I've had it for 16 years, and you can hear I'm coming back alive. In the meantime, a colleague had checked on me to make sure I'm okay. He was listening into the webinar. Very kind. But you see, the dyskinesia, even today, I am able to control it more when I have more discipline. Because when let's face it, I'm the first one to admit I don't take my own advice, but if I do my day correctly with exercise and eat the right things and drink the right things, my day is way smoother. My dyskinesia is less because I have to take less medicine throughout the day. As you guys mentioned, it's more of an art sometimes than a science how the medicine works. And I think one of the key elements in this whole process is my stomach or anybody's stomach, because it's like the key place where the medicine has to go through. As I always describe it, it's like a baseball stadium, right? If there's a game about to start and the medicine needs to get in, you want to get into the stadium, you might have trouble getting into the stadium. If there's no game going on, you can easily walk into the stadium. So that is like the amount of food that you have and the type of food that you have will inhibit the effectiveness of the medicine coming into the place where it needs to go in the dopamine into your brain. And so sometimes I have this experience where I have taken medicine, it's not working, I'm in agony, and then I take a little bit more after 2 hours, and then all of a sudden it's like a floodgate opens, and the medicine rushes in, and I have way more than I need, and it's like the dyskinesia is extreme. But so I'm sure people listening can have the similar kind of experience.
No, it's such an important and useful point, and Joe Jankovic, as Jean-Paul is suggesting, this is part of why this is such a difficult problem to solve, that intense variability, and why, as you said, there's still such a large unmet need to find a more continuous way of delivering levodopa so that you're not quite so subject to these troughs. And as Jean-Paul correctly points out, even sometimes what you eat can affect the way in which the medication moves through the intestinal system and eventually works its way to your brain. So is this an active area of research to try to, we all want to find a way, of course, to cure Parkinson's, but in the meantime, figuring out a better way to deliver levodopa would be really useful as well. Are you hopeful, I guess, about better ways of accomplishing that goal?
I am hopeful. I think the pipeline in the treatment of Parkinson's disease is quite healthy. Obviously, I would like to have even richer pipeline, but there are many medications that are currently in development and tested in various academic centers. We're doing a number of studies right now in Baylor College of Medicine in an attempt to smooth out motor fluctuations, prevent dyskinesias. But we also are looking at the ways that potentially could slow down the progression of disease. So I think there are like two areas areas of research that are of particular importance. One would be to slow down the progression of the disease right from the beginning, and there are some new strategies that are currently being developed. And the other is the topic that we are discussing today, that is to how to prevent and treat motor fluctuations and dyskinesias.
A couple of questions coming in about the impact of stress and anxiety on dyskinesia. First, for you, from your point of view, Jean-Pascal Van Houten, does stress or anxiety, feeling anxious, one person wants to know, seems to make their dyskinesia worse? Is that true in your circumstance? And if so, what tricks, I guess, or ways of contending with that have you developed?
Oh, absolutely. Stress is a huge factor in whatever the disease, but in anybody's life. But for example, if my ex-wife tries to reach me, then my stress level goes through the roof, and yes, I get very anxious but there's positive and negative stress factors. Sometimes if you're really excited about something and very emotionally attached to some exciting thing like sport or anything, then it will over-exaggerate the movements too. But both negative and positive stress factors.
And Chris Bishop, just a brief follow-up comment from you on this, because one of the fascinating things about the work you're doing with serotonin is that we know that also has an effect on mood, and that drugs that regulate the serotonin system can often be effective in dealing with depression and anxiety in Parkinson's or in other circumstances. So this is an interesting area of intersection, isn't it? Because what Jean-Pascal is describing about the effects of anxiety and depression perhaps in some ways tie into the mysteries that you're trying to solve in the way in which the serotonin system works inside the brain.
Yeah, absolutely. So some of the, serotonin, although I first talked about it in sort of a movement point of view, is really known best for its role in affect and mood. And many of the current compounds that are out there that are administered to folks who are suffering from depression or anxiety are really based on their effects in the serotonin system. And so it provides us with some interesting opportunities, because we have FDA-approved compounds that are approved for use in humans right now, that appear to work in some of our preclinical models in reducing dyskinesia. And so if we can, one, understand the system better through some of our basic research, but also show in our preclinical models that these compounds can perhaps be beneficial in optimizing L-DOPA treatment, then I think we have some fast, translatable opportunities for the patients that are already in the pipeline.
That's very exciting stuff. Just have time for a couple of last comments. So to you next, Joe Jankovic, about where you see this research going forward, and how important it is for people to deal with this in a way that works best for them. Jean-Paul made the important point that for him it's better to move than not move. For some people, depending on their profession, they might want to deal with their dyskinesia. So I guess advice from you on people who are struggling with this about the importance of identifying it correctly and talking with their physician about it.
Well, I cannot emphasize enough how important it is to individualize the therapy for patients with Parkinson's disease. So my main advice to patients who have been diagnosed with Parkinson is to seek an expert in Parkinson's disease. While most neurologists are very familiar with Parkinson's disease, when patients begin to develop side effects of levodopa, such as motor fluctuations and dyskinesias, I think that's the time to seek the expert advice from a Parkinsonologist, a neurologist who specializes in Parkinson's disease, because there are many new developments in Parkinson, and I would strongly encourage patients to talk to the Parkinsologists about some of the new trials, and certainly the website, the Michael J. Fox website, has a lot of information about clinical trials. So I would definitely advise patients to look at the website to see what trials are available, particularly in the area where they live.
Sure, Jankovic, thank you. And Jean-Pascal Van Houten, a last word from you. There are a lot of people, by the way, who are eager to get in touch with you. I know you have said that it's all right for people to contact you via Facebook. So for those of you who are participating in our webinar today and want to get in touch with Jean-Pascal Van Houten, Facebook is an appropriate way to do that. And I think it indicates, Jean-Pascal, how much people have appreciated your perspective. So the last word is yours. What would you like to add about the way in which you've dealt with dyskinesia and your suggestions for people who are similarly contending with that issue?
Well, thank you. I think the most important thing is that you have to realize that you're dealing with a situation that there is no solution for yet. However, you need to take advantage of what is given us, like medicine and exercise and nutrition options, to make your life as balanced as possible so that you can really truly focus on the things that are important to you, like friends, family, hobbies. You need to get out there and do as much as you can while you can do it, and that will help your life. And also you can put the word out, get more people focused on the disease, and never give up. Never give up. And yes, please contact me if you like.
Jean-Pascal Van Houten, thanks so much for your participation today, for hanging in there through the trough that you went through partway through this hour, and for coming back strong as I know you always do. We all really appreciate your participation, as well as the participation of Dr. Christopher Bishop and Dr. Joe Jankovic. We want to thank all of you for participating today. We'll be sending a link to the webinar on demand so that you'll be able to listen again or share as you'd like. There'll also be a survey link in that email where you can let us know your thoughts about today's presentation. We also want to ask you to mark your calendars for our next Third Thursday webinar, which will be on February 18th at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific. And we're going to talk about the subject of stem cells. Whatever happened to stem cells, a therapy that seemed to be of such promise a number of years ago that's sort of slipped back from attention to some degree, but actually there's a lot of interesting things going on with stem cell research, and we're going to bring everyone up to date the best we can in our next Third Thursday webinar on February the 18th. And finally, if you have more questions about dyskinesia, join us on our Facebook page tomorrow at 12 Eastern, where we will do our best to respond to your remaining questions about dyskinesia. Again, our thanks to Dr. Bishop and Jankovic, and to Jean-Pascal Van Houten for their participation today. Thanks, everyone. I'm Dave Iverson.